Okay. Good evening. I'm Reem Hasan, general cardiologist, social ambassador of Structural Heart Disease Catheter-Based Therapists virtual meeting, which is sponsored by King Fahd Armed Forces Hospital in Jeddah, Saudi Arabia. I'm honored today to have the interview with Dr. Kim Skelding. Dr. Skelding, she's an adult cardiology consultant. She has a long experience in structural heart disease and cardiac vascular intervention with more than 20 years experience in cardiac care. We are honored to have you, Dr. Kim, with us today, and we hope that it was physical here in Saudi Arabia, but due to the issue of COVID, we have this virtual meeting this year. Thank you, Dr. Kim. Welcome.
Thank you. And I had the pleasure of being on site in Jeddah about 2 years ago and really enjoyed being able to see your beautiful country. So hopefully once again, we will be there together.
We hope so, actually. We hope to see more people in Saudi Arabia because really Saudi Arabia is a very wonderful country, having many nice environment. Dr. Kim, we know that this already virtual meeting, already the structural heart disease catheter-based therapists virtual conference covered many modalities of therapy in cardiac care, and it was concentrated to have also transcatheter aortic valve replacement as a new emerging modality of therapy of symptomatic severe aortic stenosis. We know that it started in 2002, started from accomplished this in the very high risk surgery patients and then running to intermediate risk surgery patient. Then we go to the low surgical risk patient, which was released by Partner 3 study, which gave the 1-year outcome in 2019. And again, we have the outcome, a 2 years outcome or 2 years release of outcome of this study on 2020 by Dr. Michael in ACC updates. This study, which was including the low-risk surgery patient with severe symptomatic aortic stenosis, and which show again that TAVR is non-inferior or even superior to surgical aortic valve replacement. Including this or regarding this study, how you see that we can apply the result of this study in our patient, in our practice with low surgical risk patient? Is it the patient option? Is it our maybe sometimes bias that okay, structural intervention will be less invasive than surgery, or how you deal with this result in your practice?
Yes, thank you. So important to sort of delineate two groups in that low risk group. One is the low risk group, which is still elderly, and the other is the low risk group, which is less than 65 years old. And we need to remember that in the low risk group, less than 65 years old, that was only about 7% of the enrollment in the SAPIEN trial, and only 6% in the core valve trials. And so we know very little about the young low risk group, and that really has become very controversial. We know that SAPIEN 3 at 1 year, they had an interesting outcome, which included death, stroke, and rehospitalization. And certainly they were superior than surgery at 1 year. And at 2 years, they just had a non-inferiority outcome. And then of course the core valve had the non-inferiority outcome as well in the low risk group. But again, remembering the important exclusions, bicuspid valves were excluded, aortopathy, heavy left ventricular outflow tract calcium, complex coronary disease was again not included, and moderate to severe mitral and tricuspid regurgitation. So how do we handle this? Well, there's a few things. One is, of course, the patients want a less invasive approach, and it may not always be appropriate. We know that in the surgical valve patients, that obviously the surgery is lower risk, but the degeneration of the valve happens at a much higher rate in the young population than the older population. So even surgical valves do not last as long.
Yeah.
We have data, 5 and 6 year data on the transcatheter valves, but we don't have long-term data in this group either, certainly in the low-risk patients. What needs to happen, and what we do here in the United States at most centers, is that we have a very important conversation with the patients about their wants and needs, and being very honest with the outcomes for this population. Because in a 60-year-old patient, they will undoubtedly need another valve within their lifetime. And the question is, will it be a valve in valve with TAVR, or will it be a re-op with surgical valves? And so important to remember. Also, there's a couple of things that are much more common in TAVR. Clinical leaflet thrombosis. That doesn't seem to happen as frequently in the surgical valves. Conduction disease. So maybe a group who are at high risk for permanent pacemakers should not have TAVR, because we know that once these patients have pacing in their left ventricle, if they have pacing that is going to be a permanent need, that they're going to need more hospitalizations, and their ventricle is not going to look the same as it would have without the permanent pacemakers. Paravalvular leak, which is very infrequently seen in the surgical population, is a marker for adverse events in the transcatheter patients. And so again, I think that we need to remember that the reason for using transcatheter valves is that they are equal to, or they are better than, surgical valves. And in certain subsets of patients, we might right now, with the available data, avoid transcatheter valves.
Okay.
Those subsets, again, are patients at high risk for permanent pacemaker, very calcified left ventricular outflow tracts, and very calcified bicuspid leaflets with fused leaflets. Those folks tend to do worse. The other question comes up is repeat procedures, and what should we do? And there's only one nice, well-done paper in surgical AVR after TAVR. And in that paper, the patients did much worse with the reauthorization than they did after a regular SAVR. And so we need to remember that. Now, this population was a little odd, and we certainly need to have better randomized trials in this population because we don't know enough. And some are recommending that the initial procedure be a TAVR, and then they were young enough at 10 years or 15 years to have a SAVR. And then if they live long enough, we do a valve in valve, TAVR in SAVR. And that's a pretty big leap of assumptions, but with the available data, it seems reasonable.
Yeah, actually, we still have this concern about the durability of TAVR, especially in young patients. The more the patient is young, the more he will live. So still have this concern because, as you told, that we still have no enough data how this TAVR will last with this patient. I think they still in partner 3 also they need to extend, I think, up to 10 years to have more data about the valve deterioration and how many years this valve will last. But as you told, the problem that already the randomized sample of the study was over a patient about 70 years old, which was not the same patient as it's 40. This is our concern actually. I think we have too much advance every day in TAVR currently. You feel that every day have something new in TAVR procedure. So in your practice, usually which valve usually you feel that most of the patients, they are doing better with it, with better profile of the valve? Is it because of less paravalvular leak, better durability? Is it some valve that you feel between the different valves available now?
Interesting question. So we have two that are widely commercially available, the Edwards Sapien and of course the Medtronic core valve.
Yeah.
And there is recent data to show that the effective orifice area is better in the Medtronic valve and less patient prosthetic mismatch, and is a little more forgiving potentially with placement and making sure that you have optimal valve utilization. Now, the Achilles heel, of course, is the patients who need a permanent pacemaker. And we really need not to diminish the importance of pacemaker usage after these valves, because it certainly leads to a higher mortality. And so I think it really needs to be individualized. And you need to look at all of your patient characteristics, and you need to think very long and hard. You know, there are certainly pros and cons to each valve. And I think the best centers do it well when they take into account with true honesty the pros and cons of the valves utilized with the patient characteristics in mind.
Yes. Okay. You were telling, doctor, about the future of possible valve in such patient with TAVR who maybe they have some deterioration of the valve over years. What usually the characteristic of those patients that they will be valid or eligible to go for valve for maybe 3 or 4 times in your practice? You were doing frequently, or it's limited until now according to the advance in TAVR procedure or intervention?
So there hasn't been the longevity of the transcatheter valves to be able to know if you can put 2 or 3 valves inside. Yeah. What I think is being sort of philosophically looked at is an initial strategy of TAVR with a surgical replacement when that TAVR fails at 10, 15 years. Because then we do know that TAVR in SAVR, when again choosing the right valves with the best hemodynamic profiles, can be done very safely and have good longitudinal data.
Yes, thanks, Dr. Kim. Actually, Dr. Kim, you are from the first women who are involved in structural heart intervention, in coronary intervention, in the field of the tough side of cardiology field. And we started to see more and more from women in cardiology with better and better results. So how you see the future of women in cardiology and the opportunities that it's offered to have more women in cardiology field, especially in these subspecialties?
So for me, it was really an unawareness of the small number of women in cardiology and interventional early on that just allowed me to just continue to push on, because I never felt that I couldn't do it. And it really wasn't until really into my attending years that I realized that there were not many women in cardiology or interventional, and especially structural, to be allowed to do these things. I think that we always need to push the envelope,
Yeah.
whether it is your age or your gender or your race, to continue to do what you enjoy and what you love doing and find professionally satisfying.
Yes.
For me, I was fortunate enough to have mentors who really didn't limit me because I was young or a woman. They allowed me to use the skills that I knew and the um, background that I had to be able to go as far as I could. I think that what's important is that, especially as a woman, doing something that there are very few of us doing, that we portray the confidence that we have and that we practice with excellence. And as long as you are appropriately confident uh, and continue to strive for excellence, there should be no limits on what people can do. Certainly now there are many more women in an interventional and structural, although not as many as there should be.
Yeah.
But it is exciting for me to have a community of women who meet or exceed my abilities and expectations. And to be the first has been a wonderful thing, but I hope that the women that come after me just continue to excel and move the field forward and their careers forward in a manner that was not possible 10, 15 years ago, and is something of only our imaginations at this point.
Yes, actually, yes. With all social commitments for a woman as a mother, as a wife, as a doctor, a physician, she will do all the best. I think women in cardiology, they are doing very great. And I'm very happy to have you today in this nice interview. I hope that we will have you soon physically here in Saudi Arabia and in extra and extra upcoming meeting. Thank you, Dr. Kam. Hope we'll see you later, inshallah. Thank you.
My pleasure, and I am truly honored to be invited. Have a wonderful day.
Thanks.